12 says, "My son, hear the instruction of your father. I do not forsake the law of your mother." In Job it says, "Wisdom is with aged men, and with the length of days and understanding." In Leviticus it speaks of rising up before the gray-headed and honoring the presence of the old man. We need these things back. Our world is dying.
Everybody again.
Bring them back. Take me back to the old time day.
Early breast cancer diagnosis sponsored by the Barbados Cancer Society. Knowing the whys is wise, and we will unpack that in a second. You don't want to hear much from me. I'm going to introduce up front Dr. Elizabeth Ferdinand, who is here under the auspices of the Cancer Society to give welcoming remarks. Dr. Ferdinand.
Good evening, everyone. And now all I can say is welcome, and then I'm finished. I really had hoped that we would have a full house. But I suppose the threat of the storm, although it's slowed down now, but people didn't know that. They were thinking it was coming tonight. So we will finish in good time that you can get home safely. So don't worry about that, okay? All is well. So I want to say welcome to you all. First of all, from the breast screening clinic, our subcommittee, led by Dr. Jagu, who is right here, and many of the committee members are here. I see a few of them. Denise here and Ms. Anina at the back. But so the committee welcomes you all. I have to wear another hat because I'm also on the council of the Barbados Cancer Society, so they welcome you as well. So it's a joint welcome. I'm welcoming our guest lecturer who has come all the way from Venezuela. So we really do welcome you. This is your first visit to Barbados? Okay, all right. So you know all about us then. Oh, I'm very happy about that. So we welcome you. I hope the weather will not deter you, and tomorrow, I don't know how long you're staying, but I hope you'll enjoy the little time you have with us and come again, all right? So again, welcome to each and every one of you. I hope we will all learn something tonight because it's very important why, the whys of diagnosis of breast cancer, and then of course the treatment and what's not. But we must know about the whys. So sit back, as they would say, and enjoy the short presentation. Okay? Welcome.
I was talking to Dr. Careddu just now, and I asked her, how long will you speak? She says, I don't know. It depends on you. What we're thinking of is about 25 minutes of a talk, and then some questions afterwards fielded to you, the audience. Dr. Annalisa Careddu. She's a diagnostic radiology consultant, currently working at Caracas, and has over 30 years of experience in the medical field. She's the current director at the Center for Breast Imaging in Venezuela, where advanced courses in breast pathology imaging are taught. And she's also a professor of breast imaging for the certification program of mastology endorsed by the Venezuela Society of Mastology. She's a member of the Venezuelan Society of Mastology, and she has active participation in scientific programs of national and international congresses. For 22 years, she was the head of the coordinating committee of the Breast Imaging Center of the Policlinica, yes, Metropolitanica de Caracas, of which she was also a founder. In 2016, she moved to Bogota, where she took over the medical direction of the Centro de... Good, okay. I'm a French speaker. She graduated as a specialist in radiologist and diagnostic imaging in 1992 with a fellowship for postgraduate radio diagnosis at the Hospital Clínico y Provincial de Barcelona in Spain, 1994. She recently graduated from Fundación Universitaria de Ciencias para la Salud, Bogota, Colombia, for her postgraduate equivalent qualification as medical radiologist, and has also received a postgraduate degree in health management, 2018. She has accreditation from the American College of Radiology in breast MRI, as well as a breast course in breast pathology, imaging, Nice in France, and from the breast course in breast pathology imaging, Quebec, Canada. She was a professor at the Inter-American College of Radiology in 2011. She has extensive experience as a radiologist with mastery in non-invasive and invasive techniques related to diagnostic imaging in breast, mammography, breast ultrasound, breast MR, and percutaneous biopsies guided by imaging. Our speaker is very, very well qualified. Ladies and gentlemen, I present to you Dr. Annalisa Careddu.
Thank you for receiving me. I am very, very glad to be home. I love Barbados. I have many, many memories, and I didn't know that 50 years after I will be back as a medical doctor. So this is my name. I am Annalisa Careddu. This is our mountain in Caracas, Venezuela. It's called El Ávila. It's very beautiful. And I am very grateful, especially with Dr. Jagru. Today we are going to talk about imaging, breast imaging, that is controversial. And I would like to have all the questions you need to make so I can respond and clarify what we have to do to get early detection. Early detection, as is said over here, mammograms save lives. Early detection is your best protection. We don't know what happens and how can we avoid to have breast cancer. But we know how to cut it and how to treat it early when we can save the breast and we can also save the lives. So this is Barbados, this beautiful sea. So breast cancer is a disease in which cells in the breast grow out of control. And it begins slowly and it goes from being normal breast, then it changes to hyperplasia, then it goes to a little tumor, and it goes, we don't know the time when it goes just like a metastatic disease, but we know that when we can see it when it's beginning. Most of the patients can receive a better treatment and can have a bigger rate of survival. It is a complex disease, and we don't know yet what causes, and it's not fully understood what's happening, but we know that there are several factors. There are genetic factors that are less important than the environment. And there are these genetic factors that we have to recognize as medical doctors because they can increase the risk of developing breast cancer, and the screening that we're going to talk about, when there are risk factors, we have to begin earlier. We don't have to begin at 40 like the general population. We have to begin earlier. So it is true that we have to know about breast cancer risk factors. Gender, we cannot change it. We can have breast cancer in male, but it's very rare. The age, so when we get older, the risk increases. Drinking alcohol, I mean, real quantity, so it's okay, we can drink a cup of wine or beer or whatever, but the amount of alcohol is important. Radiation, genetic factors, hormones, yes. So you have to talk with your doctor. He is the one that will decide if you have to take or not to take hormones. And obesity. So having good lifestyle habits will be good. Let's see about the genetic mutations. All of us have this called BRCA and BRCA2. They are genes that are in our blood. But when they have this mutation, they can greatly increase the risk of breast cancer and other cancers also. The age, the risk of developing cancer increases with age, and especially after age 50. Then we will see why we get screened earlier, so each year after 50, okay? Starting menstrual periods before age 12 and starting menopause after 55 can increase the risk for breast cancer because expose the women to hormone after a longer period. Dense breast. If you want to learn about dense breast, if you have any question, I would like to respond, because when we, many years ago, learned about dense breast, it was not clear for us that it really represents a risk factor. And so we need to tell our patient if she has dense breast and what it means. It means that she has to get screened earlier, that she has to repeat it, and that many times only a screening mammogram that has 2 projections per breast maybe won't be sufficient, and she will need the called diagnostic mammogram. That it means that maybe I need another projection, and also means that she needs an ultrasound. So many times we ask, as a patient, doctor, excuse me, but I had my mammogram. Why do I need an ultrasound? Sometimes we need everything, all the package. So we need to know our breasts, to know how they look, so we are able to see any change. We need to go to the doctor, and he needs to perform an examination, a medical examination. And after 40, in the general population, we will have a mammogram. But if we have we will see the reasons to perform an ultrasound, but let's know that if the breast is dense, this patient needs an ultrasound, because the tissue doesn't permit us to see the lumps even though they are in the breast. Sometimes we have cancers that we can only see on mammograms. I brought 2 examples because they have little tiny calcium that's called microcalcification, and we can only see that on the X-ray, on the mammogram. But sometimes the cancer is a lump, so we will see it only in ultrasound. Sometimes we can see it in both methods. The importance of ultrasound is that it doesn't use radiation, so when it's needed, it's better to perform it. And in younger women, so we are noting now cancers we see in people that's younger, so they are not going to have a mammogram. But if a patient says has a lump or maybe pain or changes in the skin, it's better to perform an ultrasound. It won't harm the patient. Instead of saying, be calm, it's okay, that's nothing. So we need to be sure that's nothing. Age is no longer a guarantee that a patient is not going to have cancer because we see it also in younger people. Certain lifestyle factors, such as being overweight, obese, not getting enough physical activity, and drinking alcohol can increase the risk of developing breast cancer. So it is it's important to know that there's a complex interaction, that factors that are genetic and also environmental. That's the one that we can control. I know that you are going to ask me, but how come, Dr. Careddu? So I have a friend that she doesn't drink, and she makes exercises, she haven't taken no hormone, and she got cancer because there's so we don't know really the causes, but I like to say that having this type of recommendation in life will be okay for everything, not only for breast cancer, for all the cancers, and also to be healthy. So, breast cancer is a significant global health issue at Barbados, at Venezuela, Colombia, United States, China. It's affecting millions of women worldwide. In 2020, there were 2.3 million women diagnosed with breast cancer and 685,000 deaths globally. Breast cancer is the most commonly occurring cancer in women and the most common cancer overall. So how can we save our patients? Again, it's early detection. 1 in 8 women will be diagnosed with breast cancer in their lifetime. Breast cancer, if we see this map, it's all pink. And pink is telling us in which countries we have breast cancer as the leading cause of mortality. So it requires immediate attention and timely treatment. And there's a good news, early detection do save lives. And this has been demonstrated with scientific evidence. So it is true. So if we have the access to have especially state-of-the-art equipment, because I will always talk about it's not the same to perform a mammogram in a place where the equipment is old and has no surveillance and the technician doesn't know how to perform the mammogram. So this equipment needs people that know how to use it. The technology has to be the state of the art, the best, because we need to have great images so we can look to these little tumors that if we catch a tumor that is less than 1 centimeter, we can say that in almost all the cases, the survival rate will be more than 90%. So let's see the steps, how to prevent breast cancer really is how to detect it early. So practice routine self-exams, yes, but not only self-exams and don't getting your ultrasound or your mammography. It's all, again, we have to do everything. Know your risk and family history, yes, to tell the doctor, and maybe you need to have a mammogram earlier than 40 years old. Visit your doctor regularly, know when to get a mammogram, and follow up is very important. Sometimes when we see a cancer, the patient says, wow, but I had my mammogram 5 years ago. It doesn't work that way. 5 years ago is no good, so we need to perform each year or each 2 years, depending in the risk factors and depending also in the most risk factor and the age. Performing regular breast self-exams can help women become familiar with the type of breast she has. And sometimes it can identify a change, but it's not only performing self-exam. It is important to note that there are no a substitute for regular mammograms or clinical breast exams. So it's breast self-exam, clinical examination, and diagnostic imaging. Only to know that we talk about stages, and the stage mean the size of the tumor, the location of the tumor, if it's only in the glandular, sorry, in the mammary gland, or if it has spread. And even though we have a biopsy that says that it's malignant, if the diagnosis is early, we can have appropriate treatment, good cosmetic results that are also important, and disease-free survival. There are a lot of cell symptoms, there are signs, we know them. Change in color, orange peel, pain is important. Sometimes pain was not considered an important symptom, but it's okay to say, I have this pain, it's different than the pain I always had. We have to know our body, nipple discharge, bloody discharge, mass. But it's important to know that even though these symptoms may be related to breast cancer, sometimes the patient has no symptoms. So we don't have to wait to have a symptom to go and have a diagnostic imaging. So we can, if the patient is 40 years or less, she can have an ultrasound and we can see how is her breast, and not wait until we have a symptom. So it is important to know that there are general guidelines. I will share the one that we use also about Barbados, and we have to know the family history, also the personal health history, because if the patient had a problem, or a ovarian problem, or maybe endometrium, we have to know that, and we can screen the patient before age 40. Breast density, and it's important that the women talk with the medical doctor and the healthcare provider to know which is her risk and her family risk, and to be informed. It's a right for the patient to be informed when and how to get screened. This is the equipment that we use to perform the mammograms. It's like having an X-ray from the lungs, but it's only from the breast. And it's important to know that uses very low dose X-rays can help to find breast cancer. It's not painful, maybe in the 60s, yes. Now it's very fast, so you take about 3 to 5 minutes to perform a mammogram. These images are high resolution and go to a computer where we can see all the breasts. All of you have had mammograms performed? Yes, no? You are very young. You have an ultrasound, or not yet? There are many types of mammographers, and it's very important that this type of study, as a medical doctor, we have to decide 2 forms of how to use it. I would like that you remember what does it mean a screening mammogram. A screening mammogram is that has only 2 projections per breast. And we don't need nothing else because we don't find any sign. The patient has no symptoms. So maybe for this patient, and she has no dense tissue, it will be okay. But we cannot evaluate all the persons, all the women, only with 2 projections, because 10 to 50% of the cancers are not going to be seen in the mammogram. So we have to look closely if our patient has any sign or symptom or any sign in the mammography, so calcification, asymmetry, lump, something that maybe she requires something that is called diagnostic mammograms. If you have a report that says that you need to have extra projection, you have to take those extra projections. If you have a report that says that it's better to perform an ultrasound, it is necessary to have it done. So it means that there's something that yet has been not concluded. So we cannot go back 1 year after because maybe it will be late. Let's see some myths and realities. Mammography causes cancer by radiation. That's false. The radiation that we have in the environment is superior than the one that we get with the mammogram. So here are more the benefits than the risk. Second myth, radiation can cause thyroid cancer, and many patients ask to protect the tissues at the thyroid, and that's false. And sometimes when you put the protector, you cannot perform right the mammography because you have to be aware that it doesn't go into the breast. Myth 3, radiation causes breast cancer to spread. That is false. Mammography are sure. The realities, the use of deodorants and antiperspirants does not cause breast cancer. Wearing a tight bra does not cause breast cancer. Maybe it can cause pain. So it's better to don't use a tight bra, but it doesn't cause cancer. So there is no scientific evidence that shows that. A direct blow to the breast does not condition the appearance of breast cancer. Sometimes it happens that after the blow, the patient self-examination and said, wow, but I feel a lump. But it's not the cause of the cancer. It's only that she was able to notice. I don't need a mammogram unless I feel a mass. No. Mammography detects lesions long before they become palpable lesions, and that's the moment to perform the mammogram. If the mammogram detects an alteration, it is already too late. No. Mammography can detect cancer at its early stage when it is easier to treat, with survival rates up to 90%. And I have to tell you, 80% of the patients that come to perform breast imaging have something that's benign. So the problem is that when we don't perform the studies, maybe we're losing the cancers, but it's more frequent to have a mammogram that is normal, with normal findings, with benign findings, than having a cancer. Any question? Everything okay? Mammogram is painful and takes a long time to go for. No, it takes 5 minutes and should not be painful. It's true, you can feel some discomfort, but it's not painful. I don't need to have a mammogram. There is no history of breast cancer in my family. 80% of breast cancer patients have no family history. So we have to take our tests, even though there is no family history. Controversies about age of onset, periodicity, and completion age. For us at Barbados, these are the recommendations, the same as the American Cancer Society. We recommend to have the first mammogram in general population, the first mammogram at 40, have the option between 40 and 44 years to have the mammogram each year. Sure, after 45 to 54, mammograms every year. Women 55 and older should switch to mammograms every 2 years, or continue yearly screening. When to finish? Screening should continue as long as a woman is in good health and is expected to live 10 more years or longer. Let's talk about clinical breast exams. It says alone are not recommended for breast cancer screening in average risk women at any age. Alone, no, but all together, yes. Important to understand that what does it mean screening? Screening is the systematic examination of asymptomatic individuals to detect a disease in subclinical stage. Thus, it means when it's not palpable. And when we make that early detection with mammography, the mortality decreases between 25 to 30%. This represents a mammogram in 2 projections for each breast. If the radiology doesn't see any sign, he can decide not to perform any additional projection, but maybe for the type of tissue we'll ask for an ultrasound, just to see in this area, in the subaerial area, if there is any little lump. We are not looking for lumps that are bigger than 1 centimeter. So we're looking for little things, because 1 centimeter is a size that can change the life of the patient. It's important also to know the histology, but talking about only size, we are all the time looking for small things, calcification, lumps, asymmetries. If we find, what can we find in a mammogram? We can find calcifications. So let's see, there are the 4 main types of breast changes in a mammogram: calcification, masses, asymmetries, and distortion. Having one of these doesn't mean that the patient has breast cancer. It only means that we have to have or additional projections or an ultrasound. For example, this patient, we have our projection, 1 of each breast. It is a dense tissue. We find in her left breast these little, like salt images. There are little calcifications that we are able to see because we made this projection. And these little calcifications need to have a biopsy. And in this case, it was a carcinoma, but it was a little carcinoma. It was a carcinoma called ductal carcinoma in situ, that it means that it's into the duct. It hasn't spread. So performing a biopsy in something that's so small that we were able to see, even though the mammogram is dense, is because we performed that type of projection. This patient, she also needs, okay, let's see how it looks. We take samples. It doesn't, so we make it with, we have the equipment to make it. It's a procedure that's not painful. We take the samples, and we take them to the lab, and we wait the histology. But in this way, this patient had a biopsy, and she has no need to go to surgery for the diagnosis. She will go to surgery for the treatment, but not for the diagnosis. That was the way in the 60s, 70s that we made, so with a hook. But nowadays, you can have a biopsy, and you can have the diagnosis, and then you are going to have your treatment. The signs of breast cancer is important to know that they vary from person to person, and that there are several signs, but having a painless lung, for example, a mass, swelling, redness, warmth, skin changes, nipple changes, nipple pain, they may represent something, but not always having a symptom does not necessarily mean that a woman has breast cancer. It means that she has to go to the doctor and to get screened and to have performed the test. You, women and our patients and us, a medical doctor, we are a team. So not only is important a day, today is a day very important for us. We commemorate the fight for breast cancer, but we have to be aware all year, not only the 19th of October or not only in October, okay? So if we work together, so if we commit, so we have a commitment, we are going to be able to detect more cancer and when they are small. Every woman has a different type of breast. The important thing is to know what type the breast we have. Early detection and treatment can improve breast cancer survival rates. There is no doubt. But mammograms are not perfect, are not 100% accurate. 10 to 50% of the mammograms can be normal and the patient can have a cancer. So how can we detect it? Using the ultrasound? Yes. With the self-examination and the clinical examination. But again, when we need further testing, we need to perform it. So if a report says you need an ultrasound, it's important to talk with your doctor and say, please, the report says I need an ultrasound, so I need to perform. An ultrasound uses sound waves and their echoes to make computer pictures. And we look inside the breast. Are perfect to see those parts that a mammogram can be harder to see in this type of dance. We don't use ultrasound as a screening tool, as a routine screening tool, but it can be very helpful to see dense breast tissue, to guide a biopsy, to evaluate the lymph nodes, to determine maybe is a lump, is solid or is cyst. If it's a cyst, no problem. If it is solid, maybe we have to perform a biopsy. We have lots of techniques. We have mammography, or nowadays it's digital. We also have tomosynthesis. It is a mammography that the tube, the X-ray tube, moves one way to another, and we obtain like thin slices of the breast, and it's better, the tomo, than the 2D digital mammography. The breast ultrasound, the percutaneous biopsies, and then we have contrast functional methods that we need to put into the vein and a contrast that it's not to consider as the first line of methods, only in patient that has cancer, and in specific cases we need to go to an MRI or to a mammography, nuclear mammography. You will see in your report that we use numbers. They are called the final assessment category from the BIRAT, Breast Imaging Reporting and Data System from the American College of Radiology. And it has numbers, so we can communicate and everybody is okay. And if I say BIRAT 0, it means that the patient needs additional imaging. If it's 1, negative, everything is okay, there's no abnormality. 2, benign, she can go to routine screening. 3, it's very strange to have 3, but sometimes we need to see the patient in a follow-up of 6 months. If the radiology recommend a follow-up in 6 months, please, you have to do it. Because there is a lesion that has higher probability of being benign, but not 100%. So we have to have the follow-up. 4, it means suspicious, we have to perform a biopsy. 5, highly suspicious. And 6 is when we have the cancer. This type of alteration, this type of lesion to different patients are mammograms that show this calcium. They are cancers. We can get all the breast with this type of calcification or clusters of microcalcifications. We have to perform a biopsy. In this case, it is called the biopsy stereotaxic biopsy. If we perform an ultrasound in this patient, it will be normal. I brought this case because we cannot have ultrasound without mammograms. Because even though in this case all the breast is with all these calcifications, the ultrasound in this patient is normal. So we can have a report from the ultrasound. It will say it's a Barbados 2, no alteration or benign. So we need to have the mammograms. After 40 years old, you cannot be screened only with ultrasound. Other examples, different types of carcinoma, all represented by this calcification. 80% of the ductal carcinomas have this type of sign in the mammogram. Sometimes we can see the same alteration, yes, in the mammogram and in the ultrasound. Sometimes we can see it, and if it's in this case, we have to perform a biopsy. If the radiology is sure that the same alteration that is shown in the ultrasound is the one from mammogram, it is easier to perform the biopsy with guided ultrasound. We want to find the tumors as in this size of tumor. Two different patients with the same disease. It's a ductal carcinoma in this. This is 1 centimeter. This is 5. So it's important early diagnosis. The size of the lesion is important. Patient with also a ductal carcinoma. Now size is big, and we have another problem. Our lymph nodes are also here. So this patient has a different prognosis than the others that I showed you. So it's obvious that she has a lump. Sometimes I never judge, because sometimes we ask, but how come she didn't get screened or to the doctor? Because this lump is palpable, because we have fear. And when you feel fear, you don't want to know, and you don't talk with anybody. But it's important to know that even though we have a patient with this type of cancer or the lymph nodes, there is a treatment that we can offer, something that will be good, and she can survive even though we have this type of tumor. These will be different nodules, that lumps that we see in the ultrasound. We have to categorize and to determine. We need, as patients, search images that are good. We have to be informed, because image quality and radiologist experience are important. I cannot go anywhere or maybe just look and say, I will take my mammogram here, but who's working here? No, I don't know. And it's new, it's all that you have. No, I don't know. I think, for example, when the patient has to pay for the study, sometimes she has to make the decision based on that. But it's better to get informed, talk with your doctor, ask him, please, tell me where can I have done my mammography, where do you have confidence? Errors due to inadequate quality and errors due to lack of doctor experience. These patients have had cancer. but we're not able to see them because this mammogram doesn't work. It's like making a photograph and just trying to see something as you know, I don't recognize nothing. So we cannot talk, we cannot work with this type of images because we are not going to be able to see anything. Only to show you that we always talk, we must talk in our report about the density. Here we adipose means fatty, moderately electrolytic and extremely dense. It is better justified breast to perform ultrasound as a package. Not only mammography because we can have something in there inside and we are not able to see it. Many breast cancer treatments better nowadays. We have surgery, also medication, radiation, and other hormone immunotherapy, many things that are better now than it were before. Mammography, we can save lives, so that many people have breast cancer and have free survival disease. This is part of my team at Caracas, Venezuela. Working in a breast imaging center, we need everybody that works inside. I was talking with Dr. Jagger. It's important that for everybody it's important the early detection because everybody is trying and working, trying to find something that is very small because we are happy when we can detect early the breast cancer. So thank you very much.
Wasn't that a very compact, informative talk? Yes, it was. We're now open to questions. Microphone is available in the center of the room.
Hello, good night, Dr. Well, welcome to Barbados. You're welcome to come here anytime. I had to come, when I heard about this lecture on BLB, it's the first time I came in here and it's so, but it's good that we are here. So it has been very informative and I just like to say that we passed through months or so, I've been heard a lot about cancer-free patients. So here, this explanation and to see the danger that could be done, I'm really grateful to hear that there is a cure or something that causing some of these patients to be cancer-free instead of ending their life and for 30 years or more. So it's really grateful. When I heard about it, I from Venezuela, I thought I would come and give my support.
Thank you very much for coming.
You're welcome. And I'm Carolyn, that way.
Hello, good night. My name is Maria Graves. I'm going to ask a question of something that you did not speak about, and that is estrogen. When you have breast cancer, do you have too much estrogen or too little?
That's a great question. There are
Yeah.
different types of cancer. There are ones that have a lot of estrogen. Oh, I'm sorry. Sorry. There are different types of cancer. That's a great question. Nowadays, we can perform something that is called immunohistochemical, and we can look into the cancer and see what type of cancer it is and if it has or it has not estrogen. Not all the breast cancers have estrogen. You have with estrogen, without. So the thing is not to take it without the recommendation of your doctor because not every patient in menopause has to take the estrogen because you need to know if it's necessary because it could be a risk factor. But not all the breast cancers are estrogen positive.
So if it is that type of cancer, it means then that you have too much of estrogen or too little if you have that type of cancer.
If You have the one.
If you have the
If you
kind-
have the one that has a lot of estrogen, this type of cancer is estrogen dependent. But not everybody has that type of cancer.
yeah, but I mean the ones that have that type of cancer. What I'm getting at, the people that have this
Yes.
hormone cancer then.
Yes, you
If-
have more.
If that person has hormone cancer.
Yes.
If they have too much.
Too much.
Estrogen or
Estrogen.
too little.
No, too much. If
Oh.
it's that type of cancer, it will be too much.
Or too much. So what will cause them then to have too much estrogen? What causes it to have too much estrogen?
We don't know. We really don't know why. We have patients that have that type of cancer and they've never take an estrogen a pill, even though they have that type of cancer. So it's not directly related, and we don't know why that happens. In your experience, Dr. Jackson?
But what we do know, is if you've been on estrogen replacement therapy, particularly if you've been on it for more than 5 years, it increases your risk. Enough research has been done, right, doctor? Enough research has been done that if you've been on estrogen replacement, that it increases your risk of breast cancer. Similarly, oral contraceptive. Now it has been found that if you've been on oral contraceptive continuously for over 10 years, that those people's risks have also been increased of getting breast cancer. So therefore, and then the other thing is, see, if you start your menstruation early and you finish your menstruation late, menopause late, you see that length of time that you're on estrogen with your body and all that, all these hormones that your body itself produces, your risk increases. So therefore, we know today, right, Ian, that hormones, female hormones, estrogen and progesterone, increases your risk of breast cancer. So that doctor was saying that before you go on any kind of hormones or estrogen, you must be checked. You must have your mammogram done, you must have your breast survey, and probably ultrasound to make sure you're okay. And even if you go on that kind of treatment, then it has to be short term. Does that answer your question? Yes,
So can I add-
some people have more estrogen in their body than others. And you know, that's one of the things with obesity. Estrogen is stored in the fat. And that's why we're saying to people, watch your weight and that kind of thing.
So your body make that estrogen like between your younger years, your periodic, your
All the
periodic
years, all the years that you live. And you know, if you look at family history, some women don't look their age because they have quite a lot of estrogen that keeps. Estrogen is the thing that keeps us women looking good, or skin's good, or hair good, and all that. It has its benefits, right?
Yeah. So then if it has too much of it, then why should it be a problem?
Well, that's it. Good question.
A little
It's
thing
a
from me,
problem.
Shirley, if I can jump
Yeah,
in.
you want to say something about that?
She's coming from a slightly different angle, right? It is true taking extra estrogen in the form of HRT, in the form of birth control can put you at risk, but a lot of women not taking those still get estrogen-dependent cancers. We talk about the soil and the seed theory. Right now you're looking at the seed. You're trying to see why your body has failed you, but you're not looking at the fact that this tumor has evolved, which allowed you to be susceptible to certain things. So don't look at your body, look at the tumor that has formed. You've basically created a tumor that is dependent on estrogen. It doesn't necessarily mean that you're producing too much of it. It's just that the tumor needs it to grow. I confuse you. Well, I'm saying you're not necessarily producing too much estrogen. That's the bottom line. A person having normal estrogens can still form an estrogen-dependent tumor.
Oh.
Why that tumor starts, we still don't know. Right?
Oh, no. You don't know if it starts from having too much estrogen. You don't know.
Some of them you're taking too much estrogen and that was the result, but a lot of them, no. Your estrogen levels are normal, but you've produced a tumor still that's dependent on estrogen.
Yeah.
So how that tumor form then? Everyone.
You know, there are a lot of question marks about cancer. Yeah.
Yeah.
That's
Anyhow,
great
thanks.
questions.
Yes.
Thanks
Yes.
for
Thank you very much.
Dr. Careddu, we hardly see breasts in Barbados that are not dense. You know, would you recommend? Who makes the recommendation for ultrasound? Should it be the radiologist, general practitioner?
It depends on how you work and how the type of team that you perform in Venezuela, in Italy, in Colombia. The radiology can recommend the ultrasound. And many times when it's needed, they prefer that the patient gets the ultrasound in only one visit instead of going to the mammogram and then go home and then have the report. It says that she needs an ultrasound, then she has to go back. No. So we have the freedom of deciding what she needs, and it's better to perform it in the same time. Also, we would like, it's difficult, but we would like the patient get screened with, we are called breast imaging doctors or radiologists, because it looks easy if it's not easy. So we have to create the necessity that I prefer and tell your patient where to go. So I know that this doctor is good performing mammograms and ultrasound. I would like to have the study made in this place, in this type of center, with this type of equipment, because we know that equipment is very important. But I think the radiology, I think that we are a team. So I like to think that I can understand with the surgeon and the pathology and so because we are all working together. But if the patient has dense breast, for example, I've been 2 days at the center in Barbados now, and I saw all the dense breasts, incredible, and big breasts, large. So in a large breast, performing self-examination is very difficult. Or clinical examination, because maybe we can feel the surface, but we cannot go inside the breast. So I think that patient will need ultrasound. Also, not as a substitute.
Good evening.
Good evening.
Welcome to Barbados.
Thank you.
My name is Margaret Lord, and I'm a 13-year survivor, breast cancer survivor.
Woo!
But I want to say you have to take your life and your health into your hands. I did mammograms every year. And when I did my mammogram in 2010, they saw a mass, but they said it wasn't cancerous. But I got, I had some feeling, and then someone told me to get a second opinion. And that I did a second, a third. I just continue going to my doctor about it, and they repeated everything. But then I had to do not only mammogram, I had to do the ultrasound. But then what my doctor did is to put me to sleep, got the mammogram done again, put a wire, and put me to sleep and remove that tissue do a like biopsy and it was cancerous. So I want to know, you see, like if I didn't like get encouraged to carry that second opinion, I probably wouldn't be here tonight speaking to you. But thanks be to God.
Do you feel anything before? No. Okay. You went for screening and they saw something in the mammogram. That's a bit unusual. You with me, Ian? Definitely unusual. Because if they see a mass, they're supposed to follow it up. And the next thing they will recommend an ultrasound. Okay? We just don't, they should not really dismiss it. And they still didn't find anything in the ultrasound? That's very unusual. Very surprised at that. Because you don't often get both negative, huh? So what we have now is this stereotactic biopsy, which doctor was trying to explain about, that if you see something in the mammogram, something you can't feel when you are examining yourself or if you see the doctor, it's not felt with the hand, but it shows those little she showed us tonight. If you see that on the mammogram, you have to go after it. You can't feel it. So now they're using this new biopsy technique, which is just installed yesterday. And they'll be able to find that tiny little dot, less than 0.25 of a centimeter, and biopsy it. And it's so accurate that you can't miss it. 10, 15 years ago, what we had to do was go after it. You see it, yes, but you would put the needle in here and keep looking and hoping that you get it. And sometimes you biopsy it and you miss it because you look again and it's still there, so you have to go back again. But with this new thing, if you imagine a line going, say, from the top, one going from one side to the other, where they intersect, that's where the spot is. And this new machine will be able to pick up that spot, so you can't miss it. You know, technology is improving every year. But I'm very, very surprised that if somebody's got a mass and they dismiss it after the mammogram or something. No. I hope that doesn't happen to cancer society. I'd be very upset. That's good, yeah. Very good, you've done well.
Hi, good evening. Thanks again for a very informative presentation. My name is Debbie Fraser. Is there any risk to doing a biopsy? Can it make it?
Great question. No. Biopsy cannot spread the tumor, but they must be performed in a way so they are safe. So it's no patient has to go to those type of biopsy from 50 years ago when the patient was lying down the bed and a medical doctor came with a needle and began performing the biopsy in this type of technique. That type of biopsy, without looking the alteration, the lesion, going blind through all the breast, that type of biopsy cannot be performed. The biopsy must be performed with image guidance. So we have the patient, we see the lesion, we have different types of machines. We are where the lesion is, and we are going to take our needle and we are going to go into the lesion only once. And when we are inside the lesion, we make something that's called fire the needle. So it opens inside the lesion, we close, and we go out. So it's very important that it is true that sometimes the lesion is very big, but even though when the lesion is palpable, now we prefer to perform the biopsy in this way. We have many types of needles. So the health provider, you will see that we make an effort to know which is the best needle, why, what are we going to perform, how. Because if we have little calcification, as I showed, and we are going to try to perform a biopsy with ultrasound, we cannot do it because we are not looking the lesion, and we cannot go into a place that we don't see the lesion, because sometimes say, I don't have stereotaxy, but I know where the lesion is. No. To perform the biopsy, you have to see the lesion, and you have to see the needle when it goes into the lesion. That's the way, and it will be safe. Otherwise, no.
Is there anything on the horizon threatening mammography as the number one screening tool? Is there anything else out there that's available as a screening tool?
No.
Mammogram is still the best.
Well, it's the best. It is not perfect, but it's the best. Many works, many, that Tomo, but it's also a mammogram. So she has been many years. Everybody talks about mammogram. It's no good. It's painful. It doesn't. So I had cancer and nobody saw it. But mammogram is the best tool.
There was talk 10 years ago, thermal scans. We have them available here too.
Yes.
What are your thoughts on thermal scanning?
It was good, but many radiation, so it was not safe. The dose of radiation of the thermal scan was very high. So you cannot have it each year, because remember that the radiation is accumulative, so it can be harmful, okay? It was good as an image, but it was not safe for the patient. So it's mammography.
I want to go back to your question, your talk just now about the taking of the biopsy. Now, you say you put in the needle, and you can usually, with one firing, you take the sample. I have witnessed several firing. Why was that necessary? Okay. And the second question was about, you said when you're going to do this firing, you don't use the ultrasound?
We can perform with ultrasound and also with stereotactic.
With stereotactic, okay.
So depending on the needle, if you are using... Sorry. Depending on the needle, if we are using a needle that's called vacuum assisted, only we enter one time. We are inside the lesion, and it goes like a clock. It goes, and we go out, and that's it. I can use vacuum guided by MRI, vacuum guided by stereotactic, vacuum guided by ultrasound. I will be the one to decide which is better for the patient. To decide which technique I have to use, it will be where I see it better, where it's easier to perform. If I have space, I have to consider technical factors. If I use a through-cut needle, I have to have many samples. We recommend for nodules 8 samples, and for microcalcification 12 samples. That number is not necessarily always that way, because sometimes you have a lump and you perform the biopsy guided by ultrasound with the true core, and maybe you have 5 samples and they are good like samples, and you see that the lesion is getting smaller, so you can decide, no, it's okay, we finish. We must tell our pathology that we are sending fives, and we have to tell him what type of lesion it is. If there's lesion in the breast, so we have to be sure not to take all the lesion if we don't have a marker to leave. Because if we take all the lesion out and we don't have a marker and it results a carcinoma, then we are not able to look to search it, okay? So it depends on the needle and depends also in the guidance.
We have another 5 minutes.
Hi, but informative session. I have a question with regards to the staging. You had it up on one of the slides. So I'm assuming that based on this and the spread, the stage increases. Yeah?
I see.
Okay, so in stage 4, you had spread to the additional organs in the body.
That's it.
I didn't see the lymph nodes up there. So is it normal that the carcinoma virus, whatever we call it, we're not giving it a name, can spread to the other organs of the body without infecting the lymph nodes?
The breast disease, breast cancer, generally goes first to the lymph nodes. It's like the first station because those nodules are there to protect us. So it is not zero possibility, but it's very infrequent to have disease, liver disease, brain disease, lung disease, without having lymphatic disease. But there are some breast cancers that I think that's like taking another highway, another street. They decide not to go through the lymph channel and they go through these organs. That is very infrequent. But there are ways to know if it's happening because mammogram and ultrasound, we will look the breast and the axilla, also everything here in the neck and in between the breast called mammary internal chain. And then if it's a breast carcinoma invasive, it means that it is possible that it has spread to other organs. So the patient will have a liver ultrasound or a CT to see the lungs, okay?
What about men? Men and mammograms. Problems?
Men has to know their breast. Breast cancer in men is very rare, but you need to know how your breast is, if there is any lump, pain, and if there is some sign or symptoms, we have to make the same test at the same age. A man that has a symptom in the breast older than 40 has to have a mammogram. Younger, an ultrasound. And there is history of breast cancer in men, they have to get screened because they are risk population.
You had one question?
Sorry that I have to stand so regularly, but what is the best stage of a cancer, like to have a mastectomy? Can it be done like at any stage or at a particular stage?
Yes, no. If the patient has a stage 0, 1, or 2, we will try to save the breast. We have to also consider the histology and everything, but we are not considering at first mastectomy. Only in stage 3 and in stage 4 we will have mastectomy, but first we will have chemotherapy to make the lumps smaller. So now we prefer, when it is possible, not to perform mastectomy because I will tell you something, I will try to go slowly. At first, many years ago, we thought that when you took all the breath, that was safe. If the cancer wanted to come back, it wouldn't find where to go. So it was thought that taking all the breath out was very secure and safe for the patient. But when the cancer comes back, it calls recurrence, it will come back even though there is no breast.
Okay.
So we prefer to leave breast because it's not the same having a second cancer in the coastal, in the skin, in the scar. It is better if it has to come back to have breast. So our first choice, if it's possible, is to preserve the breast.
So if you have a mastectomy and it reoccur, it won't go into the breast, but it will go somewhere else.
Yes. It will go to the site of the scar of the mastectomy. And we won't have tissue there to remove. So it is clear now that if we can leave breast, we prefer to do so.
You know, 'cause if you have the breast maintained and you get a recurrence, you'll be able then to operate
Yes,
a second time.
yes.
But there's no breast, there is inoperable.
It will be inoperable.
Uh,
And even though the cancer, we have a recurrence, again, if we find the recurrence when it is little, it works the same. Early detection, including recurrence, is very important. So we have many things to offer, even with a recurrence. And we have to fight and to look and to examine and to make breast ultrasound to the side of the scar, and if it's necessary to perform also the mammography, because we have to be able to detect the recurrence when it's present.
so if you have early detection in the second
Tumor?
in a second in a recurrence.
Yes.
If you have early detection and a recurrence,
Yes.
is it then easy to treat just like a first occurrence, like a first diagnosis?
If you have breast, yes.
Or be just as once you find it early,
Yes.
as an occurrence. Okay.
You can treat it.
You can.
Wow, you make great questions. I feel at the university. Wow, sir, congratulations. Fantastic. Very difficult. Wow.
Yeah, they're tough. They're tough. Women who have had cancer, do they need to look beyond mammograms?
And they need, now we know that one of the indication of diagnostic mammogram is having, if she had cancer. So it's not recommended to be screened only with 2 projections per breast. If a patient have had breast cancer, she needs a diagnostic mammogram and ultrasound. Yes. Yes, I have a, yeah.
In Barbados, sorry. So there, sorry I'm sitting, but I've had a heart. So, Ian, in Barbados, do you think there's an indication that we should use, there's MRI now. Should we not use that more often as for the patients who have had breast cancer?
It's being used. It's being used.
Is it?
Yeah.
I have to say I love breast MRI. So after I began making in 2011, I understood the importance to have it. But it is very important to know that if you are going to perform breast MRI, you have to have something in your unit. If it's necessary to perform a biopsy, you can try to look for the lesion by second look ultrasound, second look mammography. But if you don't find the lesion you've seen in breast MRI, you have to do something. You have to do breast biopsy with MRI, hook wire localization with MRI, because we have this problem. You can also recognize maybe in the region if somebody has a unit with the biopsy and you can send the patient, it's okay. But if you perform a breast MRI in a patient that has cancer, let's say a lobular carcinoma in the left breast and in the right breast she has a little mass, even though you cannot find that mass in second look ultrasound or in second look mammography, she needs to have a biopsy, in this case performed with MRI. You cannot leave that patient with a second mass in the contralateral breast. Patients suffer a lot, sometimes 1 year with this result, looking to see who is going to perform the biopsy. And I think that we must think in our patients. So we must offer things that are good for them and not a problem. Because yes, you need a breast MRI. Okay, go and have your breast MRI. She comes back. No, I thought my patient had a cancer in the right breast. No, but the breast MRI says she has something in the left breast. And she will ask, and now, where do I have to go? No, we don't have, in all the Caribbean, we don't have any unit to perform the biopsy. So we have to do something. A surgery, and the patient we need to inform that and explain. We don't have breast MRI, biopsy with breast MRI. If it happens that something we see in the other breast, maybe you will have to have a surgery, even though it results benign. If it looks suspicious, we have to go on.
You can't leave it,
You can leave it there. And the patient can say, yes, I understood. I want to make it. I understand that maybe if I have a second lesion, it could be benign, but I need to, or the patient says, no, I won't live with that problem, or making a surgery that if it results benign, it will be an unnecessary surgery. So for the accreditation of our breast MRI units, one of the steps says the radiology has to have experience performing breast MRI biopsies. The equipment must have the system to perform breast MRI biopsy. The needle, Dr. Ferdinand, in the breast MRI has to be paramagnetic. So I have to buy another needle. So I cannot go into the unit with the needles that we use today with Dr. Jagru, because it's a magneto. So all the needles are going to be into the magneto. You cannot perform that. So you need, we need to think, we need to see the prices, to see if we are able, and if we can do it, it's better. So it's performing breast MRI in patients with cancer, and it's very useful.
Out of pocket, MRI here is almost 2,000 Barbados dollars. Most patients can't afford that. Most patients who are breast survivors settle into a routine of yearly mammograms as follow-up.
Yes.
Is that good enough?
Very good.
Yeah.
And ultrasound.
And ultrasound. Okay.
And ultrasound, because ultrasound has to look all the lymphatic that's near the place. So and see the ducts, the subararial ducts, and the lymph nodes. It has to be made mammogram with ultrasound. With a radiologist that has experience.
Experience, yeah.
Or maybe something at the beginning, it's okay when we are young, but that you see that this person has learned the technique, so has studied the technique, so not a general radiologist.
Yeah. Any other questions? Well, I must say I learned a lot. I want to say thank you, Dr. Careddu, for a very informative, up-to-date lecture. And it's workable information too that we can take away as patients and as clinicians, right? Thank you very much. We are under the radar by World Health Organization. I'll tell you about it later. They're looking at us. There's a statistic that's very scary that was published just 2 years ago in terms of cancer outcomes. So we have to do better. I mean, it has to be investigated why that statistic is there. It is very controversial. Yes. But it's bringing experts like Dr. Careddu to interchange information with us that will allow us to do better.
No, and I'm very glad to thank you for the invitation, and I love to be here, and I love the questions. Thank you very much.
Tough questions.
Very good questions.
Denise? Yes. Denise Carter-Taylor, vote of thanks.
Thank you, Dr. Lewis. Ladies and gentlemen, I think you will agree with me that the lecture has certainly lived up to our expectations. And an event such as this one would not have been possible without the support and the participation of many people. So on behalf of the breast screening program, I would wish to express the gratitude of the committee to all those who have contributed to the evening. First, thank you to Dr. Lewis for accepting our invitation and for guiding us through the evening so ably. Thanks to Dr. Elizabeth Ferdinand for offering the welcome. To our distinguished presenter, Dr. Annalisa Careddu, thanks for your willingness to travel here to Barbados and for sharing your experiences and your knowledge on early detection, imaging, and current technologies. Your presence here has certainly contributed to this evening, and it serves as a source of motivation for us in the committee and the Barbados Cancer Society to continue to work very diligently to provide a world-class service to the people of Barbados. So to you, Dr. Careddu, muchas gracias por todo que usted ha presentado a nosotros esta noche. The breast screening program is also pleased to have the support of our partners in the public sector, specifically the Ministry of Health and Wellness and the Government Information Service. Thanks also to the following entities: Halton Graphics, Starcom, the Caribbean Broadcasting Corporation, the Nation Publishing Company, Trident 10 TV, the Central Bank of Barbados for the use of these facilities. We wish also to thank the audience for responding to our invitation to come, and thank you for your participation and for your questions. And thanks to the clinical and the administrative staff of the breast screening program, the Walk for the Cure manager, and to my colleagues on the subcommittee who each played our parts based on our various roles and our talents. Thank you very much. And now I want to invite Dr. Ferdinand to present a token of our appreciation to Dr. Careddu.
Thank you, everybody. Have a good night. Get home safely. Prepare for the winds and a little rain. It's raining. It's raining? Well, we need some.
I always used to say, respect for each other goes a long, long, long way. Be careful what you use your tongue to say. I know your mom and dad and you would live long days. Why can't things be just like in the old time days?
Them days gone, Laurie Leon, man, it's time to move on. Forward, ever backward, never to the future and beyond. At least I know it in only me one that feel like the way that we dealing going wrong. I guess that's why I choose to join with you to do this song. It's not a lamentation, it's a celebration of the fact that many of we still got the motivation to step back, get back on track and attack the problem from another angle. We can't bring back the past, but we could get the present handle, sing the anthem.
Take me back to the old time days. My grandmother always used to say, respect for each other goes a long, long, long way. Be careful what you use your tongue to say. I know your mom and dad and you would live long days. Why can't things be just like in the old time days?
All in all, I know we've come a long way, but somewhere on the journey it seems like we've gone astray. One day we got to get back on course, like a winding river returning to the source. Of course, you know, the going will be slow, the path will be punctuated with highs and lows, hits and blows, yeses and no's. But heaven knows it's in the midst of difficulty that my spirit grows, from the tip of my toes right up to the top of my head.